Very good morning to everyone.
Hello.
Should I start? A very good morning to everyone. I'll be presenting a free paper on role of diagnostic choroidal biopsy in suspicious choroidal lesions. So, choroidal lesions are generally diagnosed on the basis of clinical features and combined with multimodal imaging. The diagnostic accuracy of clinical and imaging methods for medium-sized and large tumors is around more than 95% in experienced clinicians. Approximately in 30% of the patients with choroidal metastasis, they have no detectable primary tumor at the time of presentation. So the purpose of this study was to enhance the role of diagnostic choroidal biopsy in suspicious melanotic or amelanotic choroidal lesions. So it was a retrospective case series including 3 patients. The patients underwent detailed ocular examination including multimodal imaging and nuclear scans. Due to a suspicious nature of the lesions, the patient underwent choroidal biopsies via transretinal route, either via 25 gauge cutter or a 24 gauge syringe. The samples were then sent for histopathological examination for the confirmation of the diagnosis. So this is the case 1. This is regarding a 60-year-old female who complained with the decrease in vision in the right eye since the last 4 months. We can see a large pigmented choroidal lesion which was noticed at the posterior pole involving the macula. On ultrasound B scan, a multilobulated heterogeneous lesion was seen with medium to high internal reflectivity. In the ICGA and FFA is not shown here. ICGA, we can see that there is a hyperfluorescence which was there in both the early and the late phases. The OCT is very characteristically showing a lumpy bumpy choroid along with subretinal fluid and sciatic cavities as well as intraretinal fluid. We can see the compression of the outer retina. So a probable diagnosis of choroidal metastasis was considered and the patient was advised to undergo a whole body PET scan for detecting a primary cancer. However, no uptake was noted. So a choroidal biopsy was performed using a 25 gauge cutter. On histopathological examination, atypical cells were noted, and on immunohistochemistry, we could see that the cells were positive for HMB45, which is a specific marker for choroidal melanoma. Based on the tumor dimensions, which was more than 10 mm in diameter, the patient was given an option for tumor endoresection instead of enucleation, and the patient underwent endoresection of the choroidal melanoma and was doing well in the postoperative period. This is the case 2, which is a 48-year-old female with decreased vision in the left eye since last 3 months. We can see a large amelanotic choroidal lesion superior to the optic disc along with inferior exudative retinal detachment. On B scan, we can see a plateau-shaped heterogeneous lesion with low to mid internal reflectivity on A scan. On FFA, ICGA shows hyperfluorescence all throughout all the phases, and on OCT we see a characteristically lumpy choroid with the presence of SRF. Based on the clinical and the multimodal imaging, a diagnosis of presumed choroidal metastasis was made. The patient underwent whole body PET scan and no primaries were noted. In view of strong clinical suspicion, a diagnostic choroidal biopsy was done using a 24 gauge needle. On histopathological examination, atypical cells with high NC ratio were noted. And on immunohistochemistry, CK7 positivity and CK20 negativity was seen. The cells were sent for further immunohistochemistry and it was positive for napsin and TTF1, confirming the diagnosis of a lung adenocarcinoma. The patient was referred back to an oncologist for further assessment and treatment. A case 3, which was a 39-year-old female with the complaints of diminished vision in the right eye since 1 month. Large amelanotic lesion was noted nasal to the optic disc with surrounding subretinal fluid. There was an absence of drusen or any orange pigments clinically. B scan showed a dome-shaped heterogeneous lesion with a very low internal reflectivity. Lesion was hyperfluorescent on ICGA, but there was leakage seen along the vessels on FFA, and OCT of the lesion revealed a smooth dome-shaped lesion with hyperreflective material noted in the subretinal space. On PET scan, uptake was seen in the eye, but no primary was noted. And we can also see in the OCT there are inflammatory vitreous cells. Patient underwent a diagnostic choroidal biopsy. Cytological examination revealed an aggregate of epithelioid cells forming granuloma along with lymphocytes and plasma cells. There was no evidence of central necrosis. On GMC stain and ZN staining, there were no organisms which were revealed. Based on negative findings from malignancy, a diagnosis of choroidal granuloma was made and the patient was investigated according on that line. So choroidal lesions can sometimes present with diagnostic dilemmas and histopathological analysis may be required to reach a definitive diagnosis. Choroidal biopsies are of utmost importance when multimodal imaging poses a dilemma. The biopsy results may influence patient care and subsequent outcome. Immunohistochemical staining in patients with choroidal metastasis can help to locate the primary tumor and facilitate future treatment. In the current era in which majority of biopsies are now performed for prognostic purposes, we present a small case series that posed a diagnostic dilemma where diagnostic choroidal biopsy help us make a more precise diagnosis. Thank you.
So nicely presented. Do you do whole body PET CT imaging for these cases?
Yes, yes.
You did in all these cases?
Yes.
So was it helpful in locating a primary
No.
or?
None of the three. First case, it was eventually choroidal melanoma. No primary was noted. Second case was actually a choroidal metastasis. Still on PET scan, we did not notice. We did not pick up any primary. On the basis of biopsy and immunohistochemistry, we were able to reach to a probable diagnosis that the patient might be of lung adenocarcinoma. And then we referred to an oncologist. Then they took a lymph node biopsy, and then it was positive.
So neither the lymph node nor the
No.
lung lesion was picked up
No,
on
no.
whole body PET CT? Okay.
Very interesting.
Thank you.
Okay.